Okay, everyone, so now we're going to head into the third and final installment of public health data and communications. So far we've talked about kind of the compiling or collecting, compiling, and analyzing, and then presenting the data. And so now we're going to talk about how that data or information is perceived, how it's then combined to make decisions, and what are some kind of schema or models or organizational frameworks we can use to help quantify those types of decisions, and then talk a little bit about the process of healthcare decision making. So how do people perceive health information? So most of the time when we're trying to, especially in the public health context, if we're trying to educate people or give them information about something related to their health, it's usually related to something that's a risk to them. Their risk of heart disease, their risk of cancer, their risk of COVID-19, whatever it may be, their risk of sunburn or dental cavities. We're trying to help them understand the potential risks of some negative health outcomes that could occur. So risk perception is a really interesting topic, and we could do a whole course on that. There are people that devote their entire research lives to studying what are the things that go into how somebody perceives something as a risk or not. And so I would just want to draw your attention to a few things that are in this graphic. First is this lower one here, and that is that it depends on the individual themselves, right? So their demographics, right? So their age, their gender, other things about them, such as their socioeconomic status, their culture, their knowledge, right? So how much they already know about something, as well as how much information they're able to take in, process, and understand, what their values are, their own psychological traits, including are they kind of a risk taker, devil may care person, or are they a cautious person? And then optimism bias. So in general, we all tend to think it can't happen to us. And some people are more along that spectrum than others. So those are characteristics of the individual, but I want to talk about a couple of characteristics of the hazard itself. So that's this upper one here. So dread risk and unknown risk. And so those get a lot of attention when we're trying to educate people about potential health risks because they end up being pretty powerful. So dread is how scary something is to us, and that's shaped by all kinds of things. The movie Jaws, actually, the man who made the movie regrets having made it because it made people so afraid of sharks, and he felt like it really gave sharks a bad name and that was undue and not fair to them. So, for example, people are really afraid of sharks and swimming in the ocean because of sharks. But as we can see from this graphic, in terms of the number of deaths in Australia, for example, that are caused by different things, sharks 26 in this time period of 16 years, from bees and wasp stings 27, right? And then horses killed more people than sharks and bees together. And then we see, of course, drowning is just eclipses them, right? So as the book talks about, you're at much greater risk of having your child drown in your neighbor's pool than you are of having them be attacked by a shark. But that dread, how scary something is, it tends us to see the risk as much larger than it really is. So for people my generation, I'm Generation X, grew up in the 70s, we were really afraid of the atomic bomb, right? So we would have air raid drills in school. We were really worried about, nuclear war and nuclear explosions. Not that that was outside the realm of possibility back then. That was still during the Cold War. But what we really should have been worried about is the fact that we weren't wearing seatbelts at all, right? So we were all completely unrestrained in our cars, sprawled out in the back of the station wagon. Far, far, far more children died as a result of car accidents and of being unrestrained, not having a seatbelt on in cars, than certainly ever were injured by an atomic weapon. So how scary something is, we tend to see the risks to ourselves as greater. Other thing is familiarity. So if you're really used to something, you're really accustomed to it, you interact with it a lot, you tend to be really comfortable with it and not see it as posing much of a risk to you. So most of us are really familiar with riding in cars and automobiles, and we don't see them as particularly risky, despite the fact that for most of you who are watching this, if you are Generation Z still, this is probably one of the biggest threats to your life, actually, is a car accident, as we saw tragically last semester. So, things that are part of our everyday lives, we are less afraid of than we probably should be. So the classic example is then people get really nervous about going on an airplane flight. And so in this image from the classic 1970s movie Airplane, she says, nervous? And he says, yes, very. She says, first time? He says, no, I've been nervous lots of times. But people tend to get really nervous about flying on airplanes because it's very unfamiliar to them. So we see that risk as larger than the risk of something that is familiar to us, even if necessarily it isn't any riskier. So this is a standard kind of metric that you'll see. So familiarity is kind of on the up and down here. So we have unknown or unfamiliar things at the top, and then known or familiar things at the bottom as that y-axis. And then on the x-axis, we have dread, right? So low dread on the left and high dread on the right. And what we can see is that things that are high dread and that we aren't very familiar with, that are really unknown to us, we tend to think that the risk is really big, right? We tend to worry about them a lot. So, we've got radioactive waste and nuclear reactor accidents. These are things that people really worry about a lot. Whereas things that are known and don't seem very scary to us, that have low dread, we tend to not worry about very much at all. And so the sizes of these blue circles are showing you how much people rate them as a threat to their health and well-being, or how much they see them as a threat to their lives. So I just want to point out, right, so look at how tiny bicycles is here, right, because we're all very familiar with bicycles. And here's commercial aviation over here, right, so going on a commercial airline flight. When we look at the actual risks associated with these things, we see that we as humans are terrible because we get so skewed by things that we dread or are unfamiliar with. So commercial aviation is actually pretty safe. And so they used a metric here that says how many deaths and how many million hours of exposure. And what you can see is that driving, which we don't tend to see as very dangerous, is actually 4 times as dangerous. Cycling or riding a bike is actually 8 times as dangerous, but we don't tend to view it that way, right? So we get skewed, we get misled by things that are familiar or low dread. We think they are less risky than they actually are. A couple of other things that impact our perception of risk. One is control. If we are in control of something, we tend to not find it as risky or threatening. We tend to feel like, okay, well, we're going to be fine. Whereas when we're not the one in control, then we tend to be a lot more afraid of it. This also applies to the airline example. So up in an airplane, you're not in control. You have no control over what happens with the plane. So that tends to make people more afraid of airplanes than other things. Another thing that trips up human minds is large numbers. So we are just not good at large numbers at all. Once you get over 1,000, 100,000, we don't really perceive differences at all. They're just big numbers, and we're very terrible at kind of relating big numbers to even bigger numbers. So perhaps you've seen some of the memes trying to explain how much money Jeff Bezos has. Again, trying to help people understand these really, really, really large numbers. There's a great video where somebody uses grains of rice to show this. But so he's worth $202 billion. What does that mean? Well, so this one says, okay, so he makes $149,000, which would be a really great yearly salary for most of us, really, really good salary, every minute. Which still, I don't think we totally get the scope of it. Here's another one. If you worked every single day, making $5,000 a day, so that's a lot of money, that's hundreds of thousands of dollars a year, from the time Columbus sailed to America to the time you're reading this tweet, you would still not even have $1 billion, right? And you would still have less money than Jeff Bezos makes in a week, right? So these numbers are just mind-blowingly huge. We're terrible at really large numbers. And so a lot of times in health, we're looking at things that are 1 in 10,000, 1 in 100,000, 1 in 50,000, 1 in a million. We're just not very good at those. So this is why data and experts are really helpful. So we as human beings, just because of the ways our brain works, we tend to see things that are unfamiliar or things over which we don't have control or things that are particularly scary. So that's that kind of catastrophic potential or fatal outcomes. Also things that are not voluntary. And so that comes into play a lot when we're thinking about legislating certain things for health issues. We tend to see those things as way riskier than other types of things. And it really skews our perception of what the risk is. It throws us way off. So that's why we need data and that's why we need experts, right? Because then we can say, okay, what really is the risk? And let's look at the numbers. But it's hard. Humans, we like to think we're really rational, and yet there are all these other things that are at play and skewing our decision making. Okay, so let's say that we are able to set aside our biases and focus on the data and be very rational about making health decisions. So what are the types of information that we use when we're trying to decide between one intervention or one program or one project or another? So the basic information we're going to look at is twofold. First, how likely is the outcome? So how likely are we to have something good happen as a result of this intervention? How likely is it that something bad is going to happen? And then also, how important or meaningful are those good or bad outcomes, right? How good are they? How bad are they? How good or bad would that be for us individually? So in terms of how likely, we're going to use probabilities. So in this example, which was taken from the book because I liked it, they're saying, okay, let's say you have some type of a disease, and there are two potential interventions or treatments that you could choose. And intervention number one, there's an 80% chance that you're going to be cured. But there's a 20% chance that you might die as a result of the treatment or the intervention. Say maybe it's a complicated type of surgery. And then intervention number two, so option number two, door number two, there's only a 70% chance that you would be cured, only a 10% chance that you would die. In the middle here, there's a 20% chance that you might go blind as a result of the procedure. So looking at these different odds, right, you're going to kind of think about, okay, well, if I really, really, really don't want to die, maybe I'm going to pick number two, right? But if I really, really, really want to maximize the likelihood that I'm going to be cured, maybe I want number one. But now you can see that we're starting to bring into play what is the value that we place on these different potential outcomes. Another way of thinking about that is how important is it? What is the value you place on it? What is the meaning that you give to these outcomes? And so a way to kind of quantify this is something called the utility scale. And in the utility scale, if it's 100% or 1.0, that's full thriving health, whereas 0% is you're dead. Okay. Then in the middle, right? So maybe, at 10% or so is, gosh, you're not very functional at all. Your quality of life is really poor. You're in a lot of pain, but you're still alive, right? And 50 might be, well, you can still do a lot of things, but there's a lot of things that you can't do. Whereas 90% would be, oh, you're in really good health. There might be a couple things you can't do, but overall, you're really still able to enjoy your life. So that's what the utility scale is going to do for us. And now we can combine the utility that we assign to any given outcome and combine that with the probability. So here's how that works. So for intervention number one, Remember, the probability, the likelihood of a cure was 80% or 0.8. You're completely cured, so the utility there would be 1.0, 100%. So the expected utility of that, outcome is 0.8, right? 0.8 times 1. No, it's weird. We're using math for these things. But you could die, right? There's a 20% that you could die. That would be a utility of 0, so that's 0. So the overall expected utility, right, if we put it all together, 80%, right? Average it all out, 80% utility. If we look at intervention number 2, so again, being fully cured gives you a utility of 1, so we get 0.7 for that. And for this one, for the utility for going blind, they've given that a 0.5. Now that's based on population averages. If you ask a large group of people, how good or bad or horrible would your life be if you were completely blind? On average, people rate that utility about 50% or 0.5. So most people would find it would significantly impair their ability to live the way they want to live, do the things they want to do, but that life is still very much worth living. So the 20% chance of blindness times the 0.5 gives you a 0.1. The risk of death in that scenario was 10%, has a utility of 0. So the overall expected utility is also 0.8. So you can see that it could be really difficult for someone to choose between these potential options, right? Because overall, they're kind of a wash. But the difference here, and so from a medical standpoint, we would say, well, you could do this or you could do this. It's kind of 6 of one, half dozen of the other. It's up to you to choose which one seems better for you. And here's where that individual aspect is really important. Because the utility for any given outcome, other than full health or death, is going to vary from person to person. Perhaps you've known people who are blind and you know that they've lived a full and satisfying life. Or maybe you have a lifetime terror of not being able to see, and maybe that would be really, really horrible for you. So each individual is going to assign a utility measure that's going to be a little bit different depending on how much meaning that particular outcome would have for them. That's going to be shaped by their experiences, their knowledge, their personalities, their risk-taking, all those types of things. So using probability times utility to get the expected utility is kind of a nice way to see, well, is this kind of a wash on general for most people or not, right? So it helps us to look at to compare potential different interventions to each other. But when it comes to the individual patient, then that average utility isn't going to work. We're going to want to find out what's most important for them. Some other factors that go into decision making. How bad is the current state of things? So it turns out that if things aren't awesome, but they're dealable, we're much less likely to take a risk. That's called the certainty effect, right? So you don't want to risk losing what you have, even if what you have isn't great, if the potential outcome could be worse. However, if you're really bad off, you are more likely to take a big risk, right? You have less to lose. So that's called the long shot effect. You're like, so this often comes into play with a lot of different types of cancers. If someone is dying from a cancer and they're like, well, there's experimental treatment you could try. There's maybe only a 10% chance that it's going to help. And there's a very high likelihood there will be a lot of side effects. People will often choose to do that, right? So if the current state of things is very poor, you're more willing to take more risks. The other thing that's important is when the payoff happens, especially if there's a sacrifice or some pain or some cost to you involved. The pain is and the risk is upfront and the benefit is delayed, you are much less likely to choose it. So when we think about vaccinations, for example, there's the hassle of getting one, there's the pain of getting one, the side effects that you might have from the vaccine, and then it may help protect you down the road, right? So vaccination tends to be something that's a little bit harder for people to willing to do. Sometimes surgeries are the same way. There's a lot of pain up front and the benefit sometimes is significantly down the road. we tend to be really highly motivated if the payoff is soon, even if that means that there's going to be a greater cost down the road. So we place, in general, a lot more emphasis on what happens in the near term than what happens in the distant future. Because we always tend to think, well, who knows what will happen in a few years from now? Maybe they'll invent some miraculous cure or something, right? So a classic example of this is ACL ligament repairs in knees, for example. So when young athletes tear their ACL ligament in their knee, they are often presented with the option to have surgery to repair it. And a lot of people will choose that because they want to get restoration of full function as soon as possible, even though it increases their risk of arthritis down the road, right? So, but they're like, we're much more motivated by the short term. And so that's something that in economics is talked about a lot. It's called discounting. So we're very focused on near-term things. And then we all incorporate information and frame situations differently as a result of personality, culture, religion, prior knowledge, all types of things that we're going to talk about in the next unit. And then we all have different levels of risk tolerance. And I would see this all the time in my clinical practice. Some people are very willing to accept very high levels of risk. They say, hey, that's life. If it happens, it happens. And other people are much, much more careful. So some people will use condoms and birth control pills and withdrawal, and other people will use no form of birth control. Right? It was interesting in these past years, anytime I diagnosed somebody with chlamydia, usually those are people who are more willing to take risks than other people. And so we could often say, oh, so when did you have COVID, right? Because just greater risk taking in general, they're more likely to come into contact with it. So your own personal risk-taking attitudes have a big influence on the decisions that you make and how you perceive health information. The final part of this unit, it talks about the 3 modes of healthcare decision making. And I think it's important to point out that these exist and that any decision that is made in an individual healthcare level is usually somewhere along this spectrum. So informing of decision means a patient comes in, something is wrong with them, and the doctor says, we're doing this. They might say, and here are the potential risks and benefits, but not much, right? So it's very directive. This is what's going to happen. This is what I'm going to do to fix the problem that you have. So obviously, that's a very authoritarian way of doing things. So we're only going to do it when the stakes are high, right? So when we don't have time to have a discussion, or when, if we don't act quickly, the consequences could be huge. So if you come in with a heart attack, I'm giving you the medicines that we give people for a heart attack. I'm not explaining them to you ahead of time. I'm not asking your permission. I am giving them to you, right? So let's inform of decision. And I will tell you, I'm giving you some nitroglycerin to help open up your artery. I'm giving you some oxygen to help relieve the strain on your heart. I may tell you those things, but I'm not going to give you an option, right? So I'm informing you of decision. One time I was delivering a baby and the couple wanted as natural a birth as possible. And so as soon as the baby was born, she wanted the infant to be placed on her chest for skin-to-skin time, which is excellent and wonderful. But when the baby came out, it was blue and it was not breathing. And so she reached for the infant because she wanted to place him on her chest, but she did not know or understand what was happening in that moment. And it felt really pretty awful. I had to look at her and say no and take the baby away from her because then we had to go resuscitate the baby. It turned out fine in the end, but she didn't get the birth experience that she wanted, right? And we didn't have a conversation about it because we didn't have the luxury of time. So that's informative decision. Informed consent is, okay, well, here is what I think is going on with your body, and here is what I'm going to recommend. Here are the likely benefits of that, and here are some of the likely potential side effects you might experience. So An example of this might be sometimes a student would come in with a bad sore throat, and there's a medicine that we can use called prednisone, which can reduce the inflammation and sometimes really help with that sore throat pain. And so I would say, here's this medication. It's usually really helpful in treating the swelling that I'm seeing. 3 most common side effects are changes in your mood, appetite, and sleep, but they tend to be short-lived. Sound okay with you? And then we prescribe it. So that's informed consent. Now notice, in that situation, I'm not necessarily describing all of the ways in which that prednisone medication works, nor am I describing to them all of the potential but very rare side effects that could happen. Because if I were to explain all of that, we would be there for half an hour or more, right? So if it's something that's very unlikely to happen, your physician usually isn't going to discuss it with you. And so sometimes I think that makes people a little mistrustful when those things do happen every once in a blue moon. And then we have books called, what your doctor isn't telling you about such and such. But we don't usually have the time. So there's a lot of expertise and opinion that goes into making a recommendation and explaining the big pieces of that recommendation, the big pros and cons, and then making sure the patient agrees that it sounds reasonable. So the third one here is shared decision making. So this is where this will be used in healthcare when the benefits and the risks are kind of 6 of one, half a dozen of the other. And so there may not be a clear direction to choose. And so you want to give the patient as much information as possible so that they can make the choice that is best for them. So shared decision making will be often used for things like prostate cancer screening or mammography screening for breast cancer, where the data actually doesn't show a clear and significant advantage of one intervention approach versus another. And so we'll have a more lengthy discussion with the patient to help them decide what's right for them. As you can imagine, that is time consuming. And depending on the education level of the patient, depending on their ability to understand what we're describing, and depending on the ability of the clinician, of the doctor, to explain it, and also depending on the patient's comfort with making those types of decisions, it can vary a lot. Some people want to be really involved in their healthcare decisions. Other people just want the doctor to tell them what they think is best. And it really kind of runs the gamut. Oh, there's Oliver, my cat. Come say hello. All right, so that is it for this unit. Say hello. Oh, you're being a pest. Okay, so Unit 3, we talked about the scope of health communication, so where data comes from, those 7 S's, how we measure the population with mortality rates, life expectancy, health-adjusted life expectancy, and disability-adjusted life years, how we present health information, which is really hugely important. We want to make sure we do it effectively, but also accurately. How that information is perceived. So that's what we talked about in this section, talking about familiarity and dread and the outsized influence they have on our perception of risk, as well as problems with big numbers and near term versus later term, and then combining information to make decisions. So what's the likelihood of a certain outcome, and what's the value that we assign to that outcome with that utility scale? And then the 3 different ways of healthcare decision making, keeping in mind that a lot of things that happen in healthcare are somewhere along that line. All right, everyone. Thanks so much. We'll see you for the next unit.